So this is another in our series on how to get a durable, complete remission. And this video will be about the role of radiation therapy. And it might seem odd to talk about radiation therapy when you're dealing with durable, complete remissions of metastatic prostate cancer. But there is a role to play. There are a group of men who have metastatic prostate cancer, but it's limited to a few spots. Either a couple bone lesions or more commonly, much more commonly, lymph nodes in the pelvis, particularly along the iliac and obturator lymph node chains. So we've been working with imaging teams and radiation therapists to identify and treat these patients. First with the Combidex and more recently with the Farahim MRI. So of the iron-based techniques, of the Farahim is, in my hands at least, proved to be dramatically superior to my experience with the Combidex earlier. Combidex is back with a new iteration, and we'll see if it can match the Farahim in terms of clinical utility. I'll wait on that. And I like this technique because it visualizes cancer in lymph nodes, and it doesn't depend on the metabolic activity of the cancer, it just has to fill space. The competing imaging technologies are based on PET. One that's really been well established is the carbon-11 choline. That's FDA approved. There's published literature on it. It's clearly successful in imaging metastatic prostate cancer at a level that older imaging techniques couldn't do. Unfortunately, I've had little use for it because you can't put the patient on any drug that slows the metabolism of the cancer. In particular, Avodart can't be used. And we have a randomized controlled trial in Europe of placebo versus Avodart in men with PSA recurrences after prostate cancer. And Avodart reduced the risk of men going on to hormonal therapy by 55%. And I'd have to stop that drug, and it's not a simple matter. The drug has a 6-week half-life. So for the drug to wash out, you're dealing with being off the drug for several months. And since it's a proven efficacy, I have difficulty doing that. Carbon-11 acetate doesn't appear to have that problem, but it does require the cancer to be metabolically active. So it tends to be most useful in the more rapidly growing prostate cancers. If the doubling time is faster than 3 months, the carbon-11 acetate is likely to be significantly better than the Farahim, much more sensitive. But that turns out to be an advantage of questionable worth, as we'll get to in a minute. So who's likely to have oligometastatic disease? Well, it turns out cancers with slow doubling times. Our best success has been with patients with doubling times of slower than 9 months. A very high percentage of those patients, the cancer is limited to a few spots, and they seem to do very well with radiation therapy focused to the metastatic lesions. At the other end, if the doubling time is faster than 3 months, very few patients are oligometastatic. What you see is just the tip of the iceberg. There are patients, a few, who are oligometastatic at that point. But it gets to the issue of cost and benefit. Radiation is without damage, side effects, and is it worthwhile shot on the outside chance you might have oligometastatic disease? So in general, and then there's the people between 3 months and 9 months, and it's a mixed bag. And the closer to 9 months, the better off you are. Then the closer to 3 months, the less likely you are to have oligometastatic disease. There's also the issue of lymph node, bone involvement, and it's very clear there are a subset of men with bone involvement that is oligometastatic. They usually have 5 or fewer bone lesions. It's best if they're in the pelvis and lumbar sacral spine. Metastasis to the skull and ribs and forearms and upper arms are much less likely to oligometastatic than what we in the business call axial versus appendicular metastasis. Nevertheless, for the patients that fit the bill, radiation can destroy all the cancer at a metastatic site. And this makes everything else I might want to do much easier and more effective. Now, unfortunately, there's a fly in this ointment. And as we'll get to in subsequent talks, I do think that the durability of a complete remission is heavily dependent on engagement of the patient's immune system to maintain cancer dormancy. Now, I come from a background where I did AIDS research, and so I'm used to looking at immunosuppression. And the key cells in the immune system for cancer control are T cells, and those are the ones the HIV virus destroys. And there is obviously going to be a staging system for how severe the T cell destruction is. And that's stage 1, 2, and 3. And stage 3 is when HIV infection becomes AIDS and is associated with all the bad things in terms of infection that an AIDS patient's cause. And those are T cells under 200. Unfortunately, a shocking number of my patients who have undergone radiation therapy for oligometastatic disease have T cell counts, CD4 T cell counts, in the AIDS range, below 200. This past week I saw a man who just finished radiation to lymph nodes in the back of his abdomen, and his CD4 count was 54. That's something you'd only usually see in full-fledged AIDS. So it's of great concern. Where I'm seeing this is not in people with prostate gland radiation, nor particularly in the people with lymph node in the pelvis irradiated. But once the lymph node radiation goes to the back of the abdomen, it's a real problem. There are other problems with radiating lymph nodes to the back of the abdomen with IMRT that make me very discouraged about proceeding along the line further, including serious permanent bowel damage. Bone lesions, the same thing. If there's a large proportion of the patient's bone marrow irradiated in the process, those patients may have PSA control, but they're having severe damage to their CD4 T cells that are involved in both cancer control and fighting off serious infections. And since we think we need a multimodality, a combination of agents to treat metastatic disease, this rules out a whole range of radiation therapy options because it doesn't play well with others. Now, radiation therapy is improving rapidly, and it may well be that some of the advances in radiation therapy like a trilogy or tomotherapy or proton beam treatment or cyberknife may get around this. But right now I don't see that. What about systemic isotopes? Well, samarium quadramet was an absolute disaster in terms of immune suppression. Probably should be pulled from the market, personally, I think. Xofigo is surprisingly much more benign, and I'm seeing much less immunosuppression with Xofigo than I am with IMRT to the retroperitoneal nodes or multiple bone lesions. So I think Xofigo has real promise. Now, I've mentioned that I'm seeing a T cell deficit. This is a pretty new thing. So if you're a patient of mine and you've had radiation for oligometastatic disease in the past year and we haven't gotten your immune profile, contact us through the web portal. If you can't use the web portal, email me at snuffymyers@me.com and we'll get you measured right away. I do expect a tidal wave, so be patient as we work through the requests. Because of my AIDS background, I have a lot of experience in how to help you make the most of the T cells and tide you over what I think is likely a temporary immunosuppression. For those of you who aren't patients of mine and think you're at risk for this, you want the typical immune profile done for an HIV infection. And it's pretty standardized. Usually they measure the natural killer cells, the CD4 cells, the CD8 cells, CD3, and CD19. But it's usually packaged as a panel by most hospitals and major labs because it's used for AIDS patients. So radiation therapy, potentially a major role, synergistic with immunotherapy if narrowed, but severely immunosuppressive. And I mean much worse than I've ever seen with chemotherapy. Taxotere is nowhere near as immunosuppressive as radiation therapy that's done too extensively. So with that caveat, we'll be working out the details. Have a nice day.